recording. So prepared on paper, Lassa in the Heartland. We have Karen Brust and Mike Hartley here with us today, and I'm your moderator, Erica Shenoy. This is an acknowledgement of the programs that support these webinars, you can see here, and a disclosure statement for you all to take a peek at. So I just want to take a moment to introduce our amazing speakers for today. I'll start with Karen Brust. Dr. Karen Brust attended undergraduate university at Boston College and medical school at the University of Texas Health Science Center in San Antonio. She trained and began her role as an infectious disease staff physician at Baylor Scott and White Health in Temple, Texas. In 2014, she entered the role of Infection Prevention and Control Medical Director for the Temple program. And then in 2022, she joined the staff at the University of Iowa Healthcare, where she currently serves as the hospital's lead epidemiologist. Mr. Mike Hartley retired as University of Iowa's healthcare emergency manager in 2021 after a 30-year career with the institution, and you'll hear how he was brought back from retirement as part of this work. As a member of the leadership team for the UI Special Pathogens Unit from its inception in 2014, he served as its operations manager, working with a multidisciplinary team in overseeing the design and construction of the unit, as well as quarterly training of the unit's core team and conducting annual exercise. At the onset of this recent SPU activation for the management of this Lassa fever case, he was asked to return to UI and serve in a consulting role. So I guess we all thank Mike off the bat for coming out of retirement to do that amazing work. He was educated at the University of Iowa and initially worked for a decade in pre-hospital care as a critical care paramedic before joining the UI Department of Medicine in 1992 as an instructor and research coordinator. And in 2008, he was appointed as the institution's first emergency manager working under the chief operating officer. So a terrific panel here today. Here are the objectives. We're going to review the timeline and major challenges encountered by healthcare facilities with delayed recognition and eventual diagnosis of Lassa fever in Iowa. This past year, we're going to use the lens of that recent experience to identify challenges for moving from plans on paper, which many people in the audience probably have, to the actual management, evaluation and management of patients with a suspected HCID. And I'm really looking forward to the lessons learned regarding the value of planning and developing a network of relationships with local, state, and regional partners. I want to extend a special welcome to many people in the audience who actually had firsthand experience with this whole event who are joining today. And we're really thrilled to have all of you. So without further ado, I will stop sharing my screen and turn it over to our speakers.
Hey. All right, I hope everybody can see our screen. We good?
Thumbs up.
Awesome, thank you. Thanks, Erica. So, as is typical for the infection control world that we live in, this story actually starts in the middle of the night between Saturday and Sunday. I was woken up by the director of the microbiology lab, who himself was also woken up because somebody in the medical intensive care unit was trying to order a test for viral hemorrhagic fever. So just a little bit about Lassa first. It is endemic to West Africa, to include countries like Liberia, Nigeria, Sierra Leone, Benin, and Guinea. In Liberia, here, it's endemic in 4 of the 15 counties, to include Bong County, where the estimated incidence is 5 per 100,000. So this viral hemorrhagic fever is specifically caused by an arenavirus, and it's primarily transmitted to humans via ingestion, inhalation, mucous membrane or broken skin contact with food or items contaminated with rodent urine or feces. Person-to-person transmission can occur in healthcare settings through contact with infective fluid materials. The incubation period is about 2 to 21 days, and actually 80% of people have mild or no symptoms. So it's really only 1 in 5 that go on to severe disease and organ dysfunction. It typically starts very nondescriptly: fever, malaise, headaches, and then it progresses a little bit more: pharyngitis, myalgias, nausea, vomiting, diarrhea. And then lastly, it progresses to facial swelling, bleeding, and shock. The overall case fatality rate is low at 1%, but if you're a severe hospitalized person, then it's upwards of 15 to 20%. And then notably, fetal death and maternal death, specifically in the third trimester of pregnancy, approximates 80 and 30% respectively. So our patient was a middle-aged Iowan who had spent 4 months in his native country of Liberia. He had bought a plot of land there and was building a thatched roof hut in his small village, which was actually in Bong County. There were multi-mammoth rats that inhabit the village, but his interaction with the animal is unclear. He returned to Eastern Iowa on the 7th, October 7th, in an asymptomatic state. 8 days later, he developed symptoms of malaise, fever, and headaches. He went via private vehicle to a local urgent care center on the 22nd. From there, was taken via EMS and was admitted to a local hospital. So on admission to the first hospital, he arrived in a febrile but non-toxic state and otherwise had a normal exam. He did have a leukopenia and a thrombocytopenia and some mildly elevated LFTs and creatinine. After 4 days of workup, the basic diagnostic testing was unyielding, and this included a negative respiratory panel, malaria smear, and malaria PCR, as well as urine and blood cultures and negative imaging of the chest by chest x-ray and CT. So by the time he got to us after 4 days, he was transferred specifically to our higher level of care because of worsening encephalopathy and rising LFTs. He was a direct admission to our MICU again in the middle of the night between Saturday and Sunday. He was afebrile on admission. He was alert, but he was slow to respond and was following commands appropriately. He had 1 witnessed episode of vomiting. White cells at this point were notably increased from prior. Platelets remained low at 81,000, and he had a very marked rise in his LFTs, AST above 2,000 and ALT above 300. Point of care ultrasound showed trace pericardial effusion. And so that night, I was able to communicate with the accepting MICU team, and we discussed the case, but it was very clear that we had very little history driving the diagnostic decisions. And so at that point, I recommended that everybody enter the room with gowns, gloves, N95, and eye protection, and that somebody get more history about what he was doing while he was in Liberia. By the morning, our ID colleague was able to go in and interview the family members at the bedside and the patient. And we got our heads together and decided that although there were other things that were on the differential diagnosis, that Lassa fever was a possibility. And so about 11 o'clock in the morning, I called the state epidemiologist, Dr. Matt Donahue. And this is one of those serendipitous moments in the entire case. We had just met in person not 2 weeks before and exchanged phone numbers. So I literally just called him on his cell phone on that Sunday morning and we reviewed the case. The epi history fit, the incubation period fit, signs and symptoms fit, and supportive lab evidence fit. And so Iowa HHS moved forward with the approval to test, and this patient became a person under investigation. So as you can imagine, there was a flurry of activity that happened after that. So I called my boss, who called his boss. I was calling the medical director of the special pathogens unit, our biocontainment unit. He was out of town at a conference. Our emergency manager, whom I had also established a relationship with, he had actually taken a position in Colorado and had left the University of Iowa not a week before. And so after a lot of phone calls, discussions, everything, I recommended that we open up the incident command center and get all the stakeholders in the room. And this occurred about 2 p.m. This is the picture of the following day, as most of the attendings on that Sunday were actually virtual and was certainly a modified group from the usual 110 positions. But by the end of that first incident command at about 3 p.m., the decision was made to open up the special pathogens unit, or the SPU. So back to the patient. Immediately after that first incident command meeting concluded, we went down to MICU and the patient had taken a turn for the worst. And so he was intubated and required some pressor support after that. We had been in consultation with Nebraska by this point, and the CDC. And although the patient did have a long list of potential diagnoses like plague and dengue, his blood was drawn and was sent off for Lassa testing. He was at this point too unstable to move to Omaha, which is about a 4-hour drive for us. So Mike is going to talk about the readiness of the SPU, but the patient was ready. This SPU was ready and the patient was able to be accepted at approximately midnight. He really continued to worsen as the hours progressed. He ended up starting dialysis by continuous replacement therapy. He had cardioversion for unstable atrial fibrillation twice. Rheumatology was consulted because of the concern for hemophagocytic lymphohistiocytosis. He received steroids and anakinra. He had a very impressive ferritin over 200,000. The team had difficulty keeping his INR below 10, and he received multiple TAG infusions. And by the following day, he went into cardiac arrest, and there was no further escalation of care. And so just to kind of reiterate what happened here, our patient died within 34 hours of arrival to our hospital. Having said that, our Nebraska Respect partners were at our side at the 22nd hour, and we had solidified the diagnosis of Lassa fever by the 23rd hour. And with that, I'm going to hand it over to Mike Hartley to talk about the activation of the SPU.
Hello, everyone. To start with, I'm going to give you just a little bit of background on our unit. You know, our evolution into the world of biocontainment was probably not unlike many here on this webinar. The 2014 West Africa Ebola outbreak was certainly a stimulus for many institutions to start to look at their preparedness to deal with cases like this. And, you know, we are an 860-bed academic medical center, the only one in our state. And so it was determined by our leadership, probably by summertime, August, September, that we should start to explore to see if we would be able to create that capability to support our state, because we did have the medical expertise and the technical knowledge, but we didn't have the safe environment of a biocontainment specially built unit to conduct that care to make sure everyone's protected. And so by probably October, when the events in Dallas hit, I think most CEOs in the country, I think, woke up, and I've never seen so much money and effort put into preparedness effort in all my years in emergency preparedness. So between October and November, we began to intently build our program. And by the end of November, we felt we were ready to have a visit from our state HHS to verify our readiness, and they did. So by December, we became Iowa's only state-designated Ebola Treatment Center, ETC. That's the term that was used prior to the current National Special Pathogens system. And so as an ETC, we became put on the list for the CDC's Rapid Ebola Preparedness Team, or REP team, which was going around the country visiting state-designated centers to see if they were indeed ready for dealing with a viral hemorrhagic fever case like this. So by February of 2015, we were visited by this team. We were the last ones in the country to actually get a visit. And we had a successful visit, and on paper, it was said that we were ready to deal with viral hemorrhagic fever cases. You know, and then at the end of the week of that visit, CDC published a list of approximately 20 US centers that had been designated as an Ebola treatment center. We were not on that list, and it was actually somewhat fortunate that our paperwork hadn't got in yet, because then we were somewhat flying under the radar at that time. And I think our administration wasn't too upset about that at all. And so by February and further on for the next 5 years, we began a progress of trying to improve the readiness of our unit. Region 7 officials came to us later that year and said, would you be willing to sign an MOU to serve not only the state of Iowa, but all of Region 7, and that would constitute Nebraska, Missouri, Kansas, and Iowa. we agreed, and they provided some supplemental funding to help us in our efforts. So it really took us about 5 years, from about February of 2015 to February 2020, to really enhance our biosafety. And at the end of that period, in February of 2020, NETEC came in, and we have a three-person team led by Dr. Laura Evans out of Bellevue, now in Washington. People from Emory and Nebraska visited us for 2 days, and they did indeed deem us ready on paper, and we became a level 2 special pathogen treatment center. And so by March, just 1 month later, we admitted our first patients into our unit, and that was when COVID first was discovered in our state. And so that's kind of a little bit of a history. Our unit was chosen to be modified into biocontainment care because of some special features. First off, it's a pod of 4 rooms that's within a 36-bed surgical and neurosciences intensive care unit that are kind of off on their own, and they have their own separate air handler, which the air exhaust was actually exhausted directly to the rooftop, 25 feet from anything else on the roof. So it was kind of an ideal situation. It could be easily secured. It had its own air handler. And so over that 5-year period, with the sort of trickling in of some support funding, plus a fairly significant institution commitment, we put in a large waste processing autoclave, a decon shower exit in our locker space, and basically took care of being able to convert this area into biocontainment. And so you can see here we have 4 patient rooms, and 2 rooms could be utilized for viral hemorrhagic fever cases, but obviously we would prefer only 1 room be occupied at any given time. We need one of the rooms to be for waste staging and x-ray storage and our dedicated ultrasound equipment, etc. The other room is used for point-of-care lab in that situation, and there are 2 ante rooms that serve the 2 patient rooms. Activation time for this particular unit, we need to move patients out, get it ready, etc. As good as we can do it is about 4 to 6 hours. This is a photograph. Imagine you're on our special pathogen unit core team, and you're standing at the decon shower exit. You're looking back at the green zone where people come in, get on their PPE. The yellow zone or warm zone is the nurse's station area here. And then there's the hot zone where the patient room, ante room, and those sorts of areas are located. So the space is relatively small. So the activation timeline, as Dr. Brust mentioned, is that after the order from the CEU to activate, those patients that were already in this sidecar area of our SNCU, as we call it, were relocated, and that took some time. By about 5 in the evening, EVS came in and did a terminal cleaning and disinfectant of that space. We began to bring our assets up from a bunker that's in a considerable distance away in another pavilion to activate our unit. We began testing of our autoclave, and unfortunately, that's when we got the first bad news. Our autoclave was not booting up properly. The doors wouldn't open. And so our facilities engineering folks notified repair team, but we were told they could not arrive till sometime the next day. So that's our first set of bad news. And so as our equipment was being brought up, continuing to convert the unit and bring up our supplies and getting supplies out that we don't need, during all of this time, I was in Wisconsin at a family event. I suddenly get a text message from a person who claimed they were the new COO of University Hospitals, and they said, "Are you willing to take my phone call?" And I thought, that doesn't sound good. And so 4 hours later, I found myself at 7 o'clock with a temporary appointment and continuing the readiness of our unit. By 10 p.m. that evening, we were getting very close into being ready for the patient. And I remember sitting in the patient's room with the nursing director. We were getting it ready for the lab draws and things that would need to be done. I turned over and looked at over my shoulder, and I saw one of the most welcome sights you can ever imagine. This is the team that was dispatched from the University of Nebraska's biocontainment unit, our level 1 respec. And these people were walking in, and I'd had a 10-year relationship with these folks. And so to see Jackson, the coordinator of the respec, Kate, the Nebraska Biocontainment Unit nurse manager, and Angie, the director level person also over our National Quarantine Center, walk in, was a godsend. They were our instructors. These are the people that taught us what to do. And so they got to work immediately to start to help ready for this patient, get us ready for these patients. And so they got right to work working with our core team. We had 5 nurses ready to go. 3 were donned in our gear. They helped them do that. They started discussing the care plan for the patient and how it would be done. We did some just-in-time training for our EVS and security teams because there was a lot of turnover during COVID and whatnot. And so by that time, getting close to about 11 p.m., we're ready to go down and get the patient. So the team went and got the patient, brought them up from the MICU in another pavilion, and they were admitted into our special pathogens unit. This is a view from our cold zone through the nurse station into the patient's room. Patient was in critical condition, as Dr. Bruss discovered and discussed with you. Intensive efforts to try to stabilize the patient were ongoing. I can remember about 1:20 in the morning, I was standing in the cold zone talking to Angie, who was in PPE and monitoring our team, and my phone buzzed and I looked down and it was our lead epi nurse texting me that the testing that Dr. Brust had mentioned earlier had come back as a presumptive positive for Lassa. And I simply turned my phone to Angie and said, look at this. And her eyes just got super wide open. She had no inkling that this would really be positive because of the rarity. I mean, now we had only the 9th case of Lassa fever that had been in the United States over the last about 50 years. So the likelihood of this being positive, we thought was pretty remote. But nonetheless, efforts continued. The patient was stabilized by about 0400, and the team showered out that first began care. The Nebraska team showered out. They went and got some rest in a hotel. I left for a couple hours, and then we all got ready for the Hicks briefing the next morning, because now we had a totally different thing to deal with. We now had a presumptive positive in the state of Iowa, and we started working with our internal and external communication partners because now we needed to get the word out. And so you can imagine what that was like. And again, ultimately working with the CDC taking the lead. While all that was going on, unfortunately, the patient's condition, as Dr. Bruss mentioned, started to deteriorate even further. The patient suffered an arrest and was not resuscitatable. And so, unfortunately, the patient expired. And I can tell you, honestly, this really affected our team. We built this unit and we built our program all around serving the patient's needs and having positive outcomes. This was not the outcome that we wanted. And so, unfortunately, our team had to deal with that. And I remember them pausing, and then a prayer session was started by our team for the patient and his family. And when that was over, at about noon, we really started to work on initiating our decedent care protocol and do the initial work inside the room. And our community partners and state partners began to work on efforts to create a final disposition. So I'm not going to go through decedent care in any great detail. This could be an hour in and of itself. We just did this with our Barnes partners in St. Louis last week and kind of went over it with them. But the bottom line is, one of the issues we dealt with is we did not have a mortuary service on record willing to work with HHS for assisting the patient and the family. They went through a list of about 18 possibilities and weren't having very much luck initially. And so we had a backup plan that we put in place back in 2014, where we bought a single body cooler that we put out on our loading dock in our decedent care center in case such a case would happen. And we readied it in case it was needed. But fortunately, a service provider was found. The final logistics planning then began with the family, spiritual services, and with the state as far as transportation to be able to now finally give the family and the patient final service and closure. And so we were able to get on board a virtual family spiritual service that we conducted via a secure platform, video platform. That began at about 5 p.m. that evening. And once again, our Nebraska partners stepped up to the plate because they had actually been through this themselves. And so they came into the room, into the hot zone, and assisted our staff in getting this done because they had one of their Ebola patients back in 2014 suffer a similar fate. And so they were, again, an incredible help to our staff. In the meantime, we got our county ME on site. I called them at about 7 p.m. After the service was over. They were staged and ready to go. The team was assembled, equipment was obtained, and really the message with this, folks, is now it's slow, meticulous adherence to protocol because of the very high viremia that the patient has in their body. They are the most dangerous at this point to others. And so this has to be done very carefully, very slowly, and done the right way. And so just, you can kind of see here, 2 carts were brought in, 3 body bags, slider boards, bioseal system, etc. Not going to go through this a great deal, but a sealing lift is critical, very important to have. Then the bioseal and initial bag can be placed. Biosealing by 2 irons, that took some time, getting them enclosed. And in all these steps, there's bleaching of the containing product, glove changes, things like that. So a lot of meticulous things happening. Then when ready, the carts are brought in, 1 cart in the warm zone, 1 cart in the cold zone, and a body bag and a slider board open, ready to go, are used to move the patient out systematically into the cold zone. And then finally, once done, the patient can be moved really from the special pathogens unit without a great deal of PPE at all. And so that was done directly down into our decedent care unit. HHS had arranged for transportation by one of our 4 EMS services. Patient was taken to a facility, and cremation rights were accorded, and they worked with the family at that point. And so, now the reactivation of our normal operations and deactivation of our biocontainment unit can be done. And so we had 2 separate processes kind of going on simultaneously. We had the original MICU unit that we just basically left and in place, and nobody had entered it. And then we had our special pathogens unit. And really the process for this is simultaneously trying to be done, and the process is the same. First step is to get all the category waste packaged up and either autoclaved and disposed of in barrels. Our autoclave, remember, was not working. We finally got it fixed on Tuesday at the late end of the day because of some additional work that needed to be done. And so that waste had been sitting for some time and not able to be processed. Once all that's done, of course, you do an initial bleach wipe and mopping. We actually did that when the decedent was still in the room to cut down on the bioburden as rapidly as possible. Then we allowed for 72 hours of desiccation with a negative air pressure system running, and at 20 air exchanges an hour, that provided a good amount of desiccation. A dry virus is much better than a wet virus, right? And then after that's done, our core team nurses went in to do a primary bleach wipe and mop of all surfaces, walls, equipment, floors, etc. Another 24 hours of desiccation, another secondary bleach wipe and mop of all surfaces, all equipment was done after that. And then 24 hours after that, I went in with ionized hydrogen peroxide system and used ionized hydrogen peroxide to disinfect both rooms. And then all the PPE gear comes off when it's safe, and the EVS folks can see us sitting in the room with no PPE. They're comfortable now to come in and do that aesthetic clean and get the unit ready for normal operations. A couple glitches we ran into, of course, was the autoclave issue. Now, again, our friends at the RESPTC in Nebraska hooked us up with the Region 5 RESPTC in Grand Rapids, and they had a waste vendor agreement where their waste is actually barreled up and hauled away by the waste vendor. And so we talked with them. They happened to have the same vendor we did. We were able to get our waste management contract modified to include category A, but then we ran into a little problem with the federal DOT. The DOT transport permit that our waste vendor had was only good for Ebola and Marburg. Lassa was not on there, therefore Lassa was not allowed to be transported. So again, our friends in Nebraska called their friends at the CDC, who then called the federal group in the DOT, and they were able to get our the transport permit updated much faster. We were told it was going to take 10 days. They got it done in 48 hours. So that was great. Then we were able to finally get everything else done, and we actually filled 24 barrels with waste, and we were doing simultaneous autoclaving at the same time because remember, again, we have 80 total bags of category waste A waste to deal with. We ran out of barrels, and so we had to order 18 more. They didn't come till the following Monday, and this was on a Thursday. And so, it took us some time to get everything bagged up, barreled up, and finally either in the final groups of waste autoclaved. But finally, we were able to do some terminal disinfection of the unit, and it was back in action by November 5th. And so a lot of autoclaving, those barrels were a godsend. We had a lot of equipment and materials and electronic equipment to disinfect, and the ionized hydrogen peroxide that was used kind of did the cap and final disinfection of the unit. But then this response is not over. Let Dr. Bruss now come in and talk about the rest of our story.
Okay, so risk assessments and monitoring. This was really driven by Iowa HHS. So, there really was a consideration to consider the gamut of exposures that occurred. I don't know how, but out of the 180 total persons exposed, only 8 of them represented household and community members, which left us with 172 healthcare associated contacts to do monitoring on. Now, everybody, every EMS, every hospital, every urgent care center is represented in this top box here. And they had 67 exposed persons, of which 50 were deemed high risk. Of those 50, 45 were deemed high risk because of at least one PPE omission. 5 of the 50 were deemed high risk because of skin-to-skin contact. So this would be somebody like phlebotomy. Now at our hospital, we had 68 exposed persons. 25 of them were deemed high risk, 24 because of PPE omissions, and one of those 25s was the nurse that actually cleaned up the MSS. Now, just kind of cutting to the chase, right? There were 0 transmissions that occurred in this entire 180 exposed groups. Now, I want to call your attention to the number 2 here. These are folks that were basically asked to quarantine from others and were excluded from work. But you see, there's a big difference here. Only 5 people in the 4 days prior were asked to quarantine. However, all 25 of us were asked to quarantine. And why is that? The reason really is twofold. The first reason is if we took 45 people out of work in the Eastern Iowan region, we would have brought the healthcare system to a halt. And so the decision was to not go that route. For us, there's also kind of a scientific explanation, and that's that the patient really moved from a clinically stable scenario to a clinically unstable scenario. And so, kind of from a dry to a wet state. And of course, now we know that he passed. And so the level of viremia was quite high in those hours prior to death. And so, I want to call attention too to these 24 that had PPE omissions, just because if anybody was listening, right, I said that we were kind of in full gear up front. Well, we had gowns, gloves, eye protection, and surgical masks that were done at the very beginning, not N95 masks. And therefore, those 24 went into quarantine. So I do want to say that the people that intubated the patient were in N95s, which was kind of gave me comfort as we were going through the whole event. And I bring that up in part 2 because I think there was some level of protection that occurred both in Eastern Iowa with droplet precautions and with us in kind of a modified airborne precaution scenario. So as you can see, this was a huge event. 4 household members, 4 community members, 75 high-risk healthcare workers that were monitored during a 21-day period. It took an active coordination between 3 healthcare systems across the state, 3 EMS units, 3 counties in Iowa, 1 county in Illinois, Nebraska, CDC. And so it was a really massive coordination effort. And Iowa HHS ran command and control. And in my opinion, it was the smoothest response effort that I have ever been a part of. And I attribute that in large part to this daily fusion cell forum. It was a daily call with all partners at the table, and there was a very rhythmic cadence to the meeting. So our Iowa HHS leader, which was typically Dr. Donahue, would walk us through, this is day X of response. This is our mission, no ongoing transmission. And then we would cover the 3 priorities for the day. These kind of changed potentially day to day. We reviewed, questions from the day before. We brought questions the day of that we needed to get through. We were really ensuring that the people that were high risk and needed to be kind of found and asked to quarantine were excluded, et cetera, et cetera. And then I'll talk a little bit more about testing symptomatic contacts. And in the end, I don't have to tell this group that communications amongst this wide group of people was tricky, but I found it to be very open, very transparent during the meetings. And I think that because of this phone call, there was a real sense of calm in what I think would have otherwise been a very disorganized and very chaotic event. And so remember that it took us 8 days to fully remove all the waste and decontaminate our special pathogens unit. And so for 8 days, any symptomatic person had to be cared for at one of the other kind of level 3 hospitals. And so they were putting their own preparedness plans into action. But on the 8th day, we were open again. We were hoping that we didn't have to take care of one of our own 25 high-risk persons. But on the 8th day, of course, it happens. So our county partners were actually in charge of an e-monitoring system. And they called me, they said somebody had a fever. I happened to be on the phone with Dr. Donahue. He assists with calling that febrile patient while I was taking care of some other things. Typically, I was kind of used to Dr. Donahue getting back to me in like 5 minutes, but this time, silence, and my blood pressure would go up on a 5-minute incremental time frame. So I'll get back to that. So up until now, like I said, there were multiple patients that fit into some sort of symptomatic category. And so they were, put either into this watchful waiting. Maybe we did an enteric GI panel or a respiratory viral panel. For example, we had a nurse that went back home to her little kids. Her little kids were sick with runny noses. She developed malaise and runny nose. We put her through a telemedicine visit and a drive-through test for a respiratory viral panel. So really, in the end, we had 5 people that required blood testing for Lassa fever, of which the first 4 were taken care of in Des Moines. And so why did Dr. Donahue take so long to call me back? He ended up calling me at about the 1-hour mark, and he said, get your director of the SPU. We're going to talk to Nebraska, and we're going to talk to CDC, and we're going to figure out what to do here. And so it turned out that our symptomatic person was a high-risk healthcare worker whom had handled trash and waste and potentially infected material within the room. And she was pregnant. She was not only pregnant, she was 40 weeks and 3 days pregnant. It gets worse with her 4th child. And so if anybody is gasping, that's kind of what happened when I broke the news to our incident command center. But we decided that really the top priority was a quick evaluation of her and the baby to rule out specifically chorioamnionitis. And this could be done most efficiently in Iowa City with us. And so this is how I met our OB division director, Dr. Petker, who received just-in-time training for PPE. So again, you guys know the outcomes of the story. Everything was negative. The OB evaluation showed nothing of concern. She was well, the baby was well. The blood was drawn, sent to Nebraska, sent to CDC for negative confirmation. I don't know how, but she hung in there for 72 hours, enough time to return for a second test. And between the first and the second test, Dr. Pantella, who's shown here, he's the director of our local state hygienic lab, which is just down the road from us, was able to finish all the validation and be able to just get the blood down the road for a quick second negative test and then confirmation by CDC. So she went on to vaginal delivery, and her and the baby remained healthy and well. We had planned multiple different scenarios on how to kind of take care of this particular event: vaginal delivery, cesarean delivery, what to do if the baby needed NICU level care, et cetera, et cetera. And so there was a multitude of people between NICU, high risk OB, neonatal group, everybody that sprung into action and created these workflows to be able to kind of really assist in terms of decisions with how we were going to take care of this PUI. And so, not to reiterate all this, but I just wanted to lay this out. This was a 34-hour care of one patient, and it took about 1 month of our life with intense work to do everything that was done. And so, I don't have to tell this group how some of these events can unfold. So what are we going to change moving forward? So I'm saying that this is a successful response as defined by zero transmissions. Obviously, we weren't able to save our index patient, but drilling cannot be overstated. We also had a written plan that were known by local leaders. So Mike Hartley was one of the writers of our written plan, and he was at the bedside in the SPU trying to kind of coordinate care and operations. And then we've discussed well-established partnerships across the region. That was critical. Mike had a 10-year plus relationship. Yours truly did not, but 2 weeks before, I had met the new state EPI leader. And so there was some serendipitous timing of the new partnerships as well. And then coordination and communication. There were very clear roles during this response, both externally by Iowa HHS and internally within our incident command center. We would be remiss to say that we could have, we couldn't have done that. There's always a way to do something better during these events. And I think we, moving forward, are going to drill within the space, which is a big deal because you're going to have to move potentially 4 critically ill patients out of the space. But we learned that if you're not within the space, then you're kind of doing some just-in-time adjustments and adaptabilities, which is fine. You can do it. But I think drilling within the space is what I would argue other people have to consider. And then a lot of the second bullet point, I think that we've covered. So we lacked an active EM manager. Our trained group had dwindled. Our autoclave had issues. So supplies and equipment, so you need to go out there and kind of make sure everything is good to go. And then local testing availability. I'm hoping that because of our event and SHL being able to get their testing stood up, that other regions are going to benefit from that. Earlier recognition, how could we have done this better? And I would argue that every single level should be able to identify, isolate, and inform, right? It's really kind of what drives the mitigation of some of the negative outcomes of an event like this. And without identification, you never even get to isolation and inform. Currently, we ask for symptoms at every single entry point into our system. Why? Because we're in the worst flu season ever. But when we're out of flu season, our intention is to keep travel and symptom screening up and running to help better identify. And then last but not least, I think that what went well should be scalable. And so even if you are level 4, you need to get out there and you need to meet your partners and establish those relationships beforehand. And so at this point, we do have funding and leadership support. I think the goal through all these things is to lead a calm and controlled effort and really respect those around the table that have certain expertise. I'm going to let Mike pop in.
We can't overemphasize how valuable the current National Special Pathogens system of care and the framework that's been established is critical to this country's healthcare infrastructure. Having a level 1 or a respect that can provide just-in-time training, technical assistance, regional coordination and communication, and actually send a team to come on site to a level 2 like us. We're the only level 2 in a 4-state area. Having them come in as our instructors to assist us was invaluable. So my take-home message to everyone on this webinar is know who your level 1 is, get a relationship established with them, and make sure you maintain it, because it's not a matter of if. And so the level 2s and the level 3s, unfortunately, we do not receive any kind of supplemental federal funding right now. And with the, COVID-19 situation, we had a lot of staff burnout and attrition. We went from 35 nurses down to 14 when I walked back in the room. Those kind of issues and the lack of exercises and drills and things like that, unfortunately, can inhibit the system's ability to rapidly respond. So I'm hoping in the future that this can be corrected. My final point is EMS. We have 4 trained EMS special pathogen services in our state, but the distance that these folks can travel in all of that PPE is very limited. And this country has very limited air assets that can actually fly a patient of this nature. And so that's a major issue that we also need to address, is to try to build up that EMS component. But this system is constructed correctly. We just all need to be familiar with it and support it.
And then lastly, I think there's a reason that they asked us to talk, because if it can happen in Iowa, it can happen anywhere, right? So be prepared, plan it, write it down, drill it, and get to know your partners. Those are my take-home messages, and we'll take questions.
Well, wow, terrific. I see some clapping hands. Hopefully there'll be some heart emojis too. That was phenomenal. I've been monitoring the chat and the questions, and I'm going to collapse a few of them. Oh yeah, lots of hearts. That was terrific hearing firsthand from you. And I think a lot of people on this webinar are probably imagining what you went through and are learning a lot from that experience. So thank you. So first, there were a couple questions around, I'll start with transmission. So zero transmission. There were 2 questions that came in around this. Can you comment on your thoughts on why there was no transmission in the absence of this recognition, similar to the Minnesota case about a decade prior? And also specifically comment on laboratorians and if any of those were identified as high risk among your healthcare personnel.
Okay. So to the first question, I think of kind of 3 buckets of people that were exposed: household and community members, folks in Eastern Iowa, and then folks here in Iowa City. And so we had pretty high PPE. I mean, surgical masks, gowns, gloves, eye protection. Eastern Iowa also had PPE. They were mostly in droplet precautions. And so, although there was some skin-to-skin contact there. So really, a little bit of surprise as well with the household and the community members. And so, and I can't say that I participated in large part with that. That was really driven by a CDC team that went down to the county level to work with that family. But I also don't think it's unlike in the literature, where there is some connectivity between the infected patient and lack of transmissions. And so, maybe at that point he wasn't quite as viremic and quite a threat. To the second question, the laboratorians, I feel like I learned a lot about laboratorians and the risk that's taken. And because of this event, there was a lot of learning that was involved, both Eastern Iowa and here. So we do a lot of our testing in-house. And so it was much more easy for us to go and find where all those blood samples were and to do the interview with everybody that handled it. And so there were minor issues with risk assessment and exposures with respect primarily to eye protection. Eastern Iowa was a little bit different because they use a lot of reference labs. And so to try to track some of those labs down and what happened at all the different reference labs, you can imagine was a real task at hand. So I do suspect that maybe something will change with respect to laboratorian exposures. So we'll just have to kind of wait and see what those changes are.
Terrific. Next question. And then, Mike, if you see in the chat, there was a question about the lift, and I think you might be able to answer it in the chat while we go to the question about advanced life support. And were there discussions, and it looks like it was a pretty short time frame that you had the patient with you. Were there discussions about what would be offered and what might not be offered? Can you tell us a little bit about that? As well as there was a question about really about CPR and those sorts of discussions that may or may not have happened with your team.
Yes, all of that was pre-planned. All of that was written down. And maybe when the plan was written, it was through the eyes of Ebola. And so then we had to kind of assess this particular scenario through the Lassa scenario. But to answer you straightforwardly, yes, everything was planned. The team knew that no CPR would take place. And so we certainly did quite a lot, didn't we? Like intubation, dialysis, DC cardioversion, but stopped short at CPR and probably a pericardiocentesis. I think maybe that would have been another procedure that could have been considered, but they're going in. And I would say that the critical care doctor, whom had also kind of been part of the original band,
Yes, he was.
He was very clear with the team with respect to, this is what we're going to do and this is what we're not going to do.
He was incredible.
Mhm.
Terrific. Thank you. Next question relates to waste. I think I heard 34 barrels and 34 hours of care. Is that?
80.
Yeah, so we had made plans for, per day for one patient, about 20 red bags of waste per day generated by our friends who trained us. It ended up being quite a bit more. We ended up with 80 total bags of waste. And we did bring in the initial 24 barrels. And each barrel, you could get one, maybe two, maybe three bags in each barrel. And our autoclave is fairly good size. Same ones I think they have at Hopkins. And thank you, Dr. Garibaldi, if you're listening, for helping me with that many years ago. But it can process 2 to 3 bags. And so unfortunately, the autoclave process would have protracted this thing out so far. Those barrels were a godsend. So we used the initial 24 right away, and then we ended up using about 10 more of the 18. And so we're going to keep barrels always in reserve, just in case something happens again to the autoclave. But the autoclave process is very, very tedious. It's laborious. Our core team was down. Our nurses run the autoclave. We only had 14. So you can kind of see the problem there with personnel, and hopefully build that back up again. But having the waste barrels, is just absolutely a godsend to us now.
Thank you. One more waste question. Waste is always popular. The question is, did you have to have security to lock down the waste? How did you kind of manage that aspect of it?
So back in 2014, we actually had a room identified near our loading dock that's secured and locked down for waste storage until the vendor could come and get it. And so up in the unit, one room is staging for waste until it's processed. And then once it's processed, it's taken down to this locked storage area. Well, we filled the barrels up as well and just took them down to the locked storage area. And when the vendor arrives with their truck, it is secured. It's under video surveillance. Only one supervisor in EVS has access to it. So we were able to secure our waste without any difficulty, if it had been processed or if it hadn't been processed even.
I think, can I add to that?
Sure.
So I think the other kind of piece with security was security to that special pathogens unit. And
Absolutely.
so we had somebody that was kind of stationed outside the doors, and you had to be like on a list of
A list I
folks
gave
of
them. They're
who
allowed in.
were
Yes.
allowed to enter. And I don't know if anybody caught it, but we consulted rheumatology. And in the actual consultation, it said, this is a virtual consult only. Do not go see this patient, and I thought it was interesting that the rheumatologist was like, I've never seen that happen before. So security does play a critical role during all of this. And
Absolutely.
we had even kind of discussed decedent care.
Yes.
Should we have had to keep him with us for a while before going to cremation, who would be in place for security purposes?
Right.
Mike, you mentioned the lift. Are you talking about the Hoyer lift for the
Yeah, so
ceiling?
we have a
Okay.
lift. It's got 600 pound capacity, and it's not a Hoyer brand. It's a different brand.
Okay.
But all patients in the ICUs are already on a disposable sling in their mattress. So that lift was absolutely critical in this case. And this patient was, I think, approaching 100 kilo. And so without that lift, it would have been a lot of manhandling done by our core team to move from bag to bag and things like that. So that was absolutely critical. And just a quick note, the biosealing system that we used was barely large enough. After you use the shrouding and the initial body bag and then the biosealing system, we almost needed to go to the bariatric technique, which I can discuss at a different time, where you could actually deal with a much larger patient. But without a lift, we would have been in trouble. I think it was really a godsend.
So with the last couple minutes, I'm going to use my prerogative and ask a question that goes back to the beginning, which is when Karen, you were talking to the state epi, I guess, about is this person a PUI? And you said the epi was right, and then the other part.
Correct.
Was the epi the travel, or was there an actual known exposure? Because I think with Lassa, one of the major
Yeah.
challenges is the non-recognition of exposure that the patient themselves may not realize that
And
they
I,
had an
I
exposure.
didn't call it out specifically, right? So I did say that rats inhabited the village, right? But there was no certain connectivity with that. So I think the answer, the direct answer is that he was from Bong County, where we knew that there was intermittent cases throughout the years and was basically thought to be endemic there. And then I think the other kind of piece to it was that he was building this, place of living. And so the dust that was potentially inhaled, and again, right, we're talking about this, we're using our infectious disease consultants type of brain to try to kind of make some of these decisions. That was one thing on the differential diagnosis. And, everybody was shocked that it was actually positive, but that's what we're here for, right, is to consider those epidemiological risk factors and to test if there's enough there to test for.
Yeah, I think I'm just thinking back to when this patient maybe initially presented, where we didn't have all the other negatives and
Correct.
all the other blood work. Would that have raised them up on the list or not?
Yeah.
Because I think with Lassa, it's very challenging with the lack of recognition of potential exposure.
Yeah. And I mean, I almost feel like we can apply the same thinking nowadays with avian, right? So we have so much flu going around. How do we think about avian?
Mhm.
And so I just think if you've got a fever and a traveler, you have to know where do they go? When did they go? What did they do? What did they eat? And so, I think that's ingrained in us as ID fellows, to
Mhm.
ask those types of questions, but it's not necessarily ingrained in everybody else. And so that's why we're hoping that our screening questions will kind of alert the primary care provider, and then they can tap into our team, our infection control team, our infectious disease team, walk through the cases, and then, even reach out to those public health partnerships to review the cases. And to that point, I actually talked to the ICU team about that, maybe pick up the phone and talk to somebody, see what's circulating in Liberia right now that we need to be aware of that may not be directly in front of us through CDC, WHO, et cetera, et cetera. So,
Well, we are at the top of the hour. That was awesome. All the comments in the chat and all the attendance, this was terrific. Thank you, thank you, thank you so much for everything. And there was the thanks, Mike, also for recommending that you connect with your regional center. And if you don't know where it is, it's posted online. We posted for the Region 1 in New England. Lots of hearts coming up. Thank you all, everyone. Have a great rest of your day and a great weekend.
thank
Bye-bye.
you.
Thank you.